Welcome to our video on malignant skin lesions. Let's get started. In this section, we'll go through 4 malignant skin lesions: basal cell carcinoma, squamous cell carcinoma, melanoma, and mycosis fungoides. Let's start with basal cell carcinoma. For each of these lesions, we'll go through introduction, etiology types, clinical presentation, as well as the diagnosis and management. So let's start with the introduction to basal cell carcinoma. Basal cell carcinoma is the most common malignant skin cancer. It arises from the basal layer of the epidermis. It is a locally invasive and aggressive cancer that rarely metastasizes. Therefore, it has a good prognosis. The most common etiology is exposure to sunlight, as prolonged exposure leads to DNA damage from the ultraviolet rays. Now, people who tend to work outdoors or who are constantly exposed to sunlight are at greater risk of developing basal cell carcinoma. Also, people with fair skin complexion, such as the white racial population, and albinism are at risk due to absent or reduced melanin. Xeroderma pigmentosum is caused by a defect in DNA repair, leading to increased skin sensitivity to UV radiation, and that can eventually progress to skin cancers. Lastly, chronic arsenic exposure can also lead to basal cell carcinoma. Basal cell carcinoma can be divided into many types, 3 of which are listed here. The nodular type is the most common, and it commonly appears on the face as a pink, fleshy, and nodular lesion. In this picture, there's a pearly red nodule with visible telangiectatic vessels on the tip of the nose. This is a typical presentation of nodular basal cell carcinoma. The superficial type is the second most common type, affecting the trunk region, and it appears as a scaly macular lesion. Here we have a picture that shows a pink, scaly macular lesion, which is indicative of a superficial type basal cell carcinoma. Morpheaform, or sclerosing type, is relatively less common and usually appears atrophic with ill-defined borders. And here's a lesion with a crusty, scar-like appearance, which demonstrates the morpheaform type of basal cell carcinoma. Let's move on to the clinical presentation. Patients usually complain of a slow-growing skin lesion, which look like pearly or pink papules, and these lesions may also contain telangiectatic vessels on its surface. Now, the nodular type may ulcerate, forming a typical rodent ulcer, characterized by a central ulcer and rolled-out margins. Now, commonly involved sites include sun-exposed areas, such as eyelids, nose, forehead, and upper lip. Basal cell carcinoma can be diagnosed clinically, but it should always be confirmed with a skin biopsy. On clinical examination and dermoscopy, the lesion is evaluated for its margins, telangiectatic vessels, and atrophy. Skin biopsy is diagnostic, and partial or full thickness biopsy is the preferred biopsy technique. On histopathologic examination, peripheral palisading pattern of the basophilic cells can be seen. Here's a histopathologic picture of basal cell carcinoma. Notice the nests of those basophilic cells, and those are the tumor cells. Also notice the peripheral palisading pattern of the tumor cells, meaning that the tumor cells are lined up parallel to each other on the periphery of the lumen. The standard, or the first-line treatment of basal cell carcinoma, is surgical excision of the lesion along with removal of approximately 4 to 5 millimeters of surrounding healthy tissue. Now, Mohs micrographic surgery is considered an alternative to the standard surgical excision, where the tumor is removed, ensuring minimal normal tissue loss. The tumor is removed in layers and examined carefully to ensure complete resection. Now, topical therapies like imiquimod and fluorouracil are considered second line. Now, patients who are unfit for surgery or patients with large tumors could also receive radiotherapy. Cryotherapy is another treatment, and that uses liquid nitrogen to freeze the tumor cells. A 75-year-old farmer comes to the physician due to a skin lesion on his forehead. He first noticed this lesion 3 years ago, and it has progressively enlarged. Physical exam reveals a whitish nodule with visible telangiectasias. Skin biopsy is performed. What findings are expected to be seen on this patient's skin biopsy? Okay, this is an elderly farmer with possibly prolonged sun exposure who now presents with a 3-year history of a whitish nodule accompanied by telangiectasias. This is a classic description of basal cell carcinoma, also known as BCC. Now, the question asks what the classic skin biopsy findings are for basal cell carcinoma. Now, if we recall from previous slides, a basal cell carcinoma is characterized by intradermal nests of basophilic cells with a palisading pattern. Now let's move on to squamous cell carcinoma. Squamous cell carcinoma is the second most common skin cancer after basal cell carcinoma. It arises from epidermal keratinocytes in the stratum spinosum, or the spinous layer of the epidermis. Now, the incidence of squamous cell carcinoma increases with age. Now, although the cancer is slow growing, it can metastasize to regional lymph nodes. Sun exposure is the most important risk factor for the development of squamous cell carcinoma. Now, exposure to ionizing radiation and chemicals such as arsenic and radon also increase the risk. Chronic inflammation such as burn scars and chronic ulcers can predispose to skin cancer, commonly squamous cell carcinoma, which we're talking about here. So be thinking of that as well. And conditions that lead to immunosuppression, such as HIV and organ transplantation, also increases the risk of malignancy. Now, albinism and xeroderma pigmentosum are other possible risk factors. And precancerous lesions, such as actinic keratosis and Bowen disease, can occur as a result of chronic sun exposure, which eventually progresses to squamous cell carcinoma. Here's a picture of a patient with actinic keratosis. Notice the forehead and scalp have an erythematous, scaly, and rough appearance. So let's move on now to clinical presentation. Patients can present with an erythematous papule or a nodule that may bleed. Some may present with a non-healing ulcer with typical everted edges that may look like a cauliflower lesion. And it's often slow-growing and locally invasive, and the sites frequently involved are the face, neck, and trunk. Squamous cell carcinoma often involves the lower lip, and contrast that to the basal cell carcinoma, which involves the upper lip. Now let's list some of the important high-risk features. Lesions more than 10 millimeters in size on the face, or more than 20 millimeters on the trunk if they have ill-defined margins and rapidly growing in nature, are considered high risk for developing squamous cell carcinoma. Other high-risk features include immunosuppression, a history of previous radiation, and presence of neurologic symptoms. The three main clinical variants of squamous cell carcinoma are keratoacanthoma, verrucous carcinoma, and Marjolins ulcer. Keratoacanthoma is a well-defined squamous cell carcinoma, and it grows rapidly. Verrucous carcinoma typically presents as an exophytic growth, and those can be described as cauliflower lesions. And a Marjolin ulcer is a rare type that occurs over sites of chronic inflammation, such as burns and scars. The diagnosis can be made on the basis of history and clinical examination. However, skin biopsy is diagnostic and is performed for confirmation as well as part of treatment. And various biopsy techniques can be used, such as shave biopsy, punch biopsy, or an excisional biopsy. And on histopathology, you can see these atypical keratinocytes, as well as keratin pearls and intercellular bridges. This is a histology slide of squamous cell carcinoma. Notice the classic finding of those keratin pearls. Intercellular bridges are also visible here. Now, surgical removal of the lesion, along with removal of normal marginal tissue, is the first-line management. Surgical excision and Mohs micrographic surgery are the surgical options that can be performed. Also, cryotherapy can be used to freeze the tumor cells, and radiotherapy is indicated in patients unfit for surgery or as an adjuvant therapy alongside surgery. And of course, chemotherapy is given in cases of metastasis. Let's move on to melanoma. Melanoma is a highly malignant skin cancer that arises from the melanocytes from the epidermal layer of the skin, and it can be life-threatening and often undergoes metastasis to the regional lymph nodes. Other areas of metastasis are lungs, liver, and brain. Now, sun exposure is the most important risk factor. Light skin complexion and albinism can also increase the risk of melanoma. Other risk factors include congenital melanocytic nevi, dysplastic nevi, and FAMM syndrome, or familial atypical mole melanoma syndrome. Lastly, immunosuppression also increases the risk of melanoma. Now, there are mainly 4 types of melanoma that we'll discuss here. Superficial spreading melanoma is the most common type. It has a predilection for the back in men and the lower extremities in women, and it presents as a pigmented macule with irregular borders. And it has a horizontal growth, which means that the spread of melanoma occurs in a transverse manner, and it has a good prognosis. The second type we'll discuss is nodular melanoma. This presents as a pigmented pedunculated nodule and is characterized by a vertical growth. Vertical growth refers to the growth of a lesion in a vertical manner. And nodular melanoma actually has the worst prognosis, and it rapidly metastasizes. Lentigo maligna melanoma is another type that arises from a precancerous lesion called lentigo maligna. It commonly occurs in the elderly as an irregularly pigmented macule. An acral lentiginous melanoma is the last type that we'll discuss in our lecture. It is common among people with dark pigmented skin, as well as Asians. And it's unique as it appears on the palmar, plantar, and subungual surfaces. And it has a horizontal growth, so it's spreading horizontally on the skin, and that rapidly progresses to vertical growth. And when it goes vertically, that actually is bad. And that's one of the reasons that this type has a poor prognosis. A 72-year-old male comes to the physician due to a discolored nail on his right toe. He first noticed color change 4 months ago, and it has darkened progressively since then. Physical exam shows a right toenail with non-tender asymmetric brownish discoloration and color variation across the lesion. The patient has no previous history of trauma on his right toe. What is the most likely diagnosis of this patient's nail lesion? Okay, so this patient presents with a rapidly progressive lesion on his right toenail. It's non-tender, asymmetric, and there's a color variation across the lesion. Additionally, there's no history of local trauma. All of these findings are consistent with subungual melanoma, which is a subtype of acral lentiginous melanoma. And it's actually very high yield to compare subungual melanoma to subungual hematoma, because at first glance they might look similar. However, subungual hematoma is symmetric, commonly tender, and it can be brown and be found in a patient with a history of nail trauma. But those clinical findings are not found in this patient. Now, this is a typical picture of subungual melanoma. It shows those brown-black streaks on the nail plate with those irregular borders. And these lesions are commonly painless. And here's a picture of subungual hematoma that looks quite similar to subungual melanoma. Although both conditions cause pigmentation in the nail, subungual hematoma has a uniform pigmentation with regular borders, and it's often painful. Now, melanomas might present with the ABCDE criteria that refers to the various findings. So let's go through these features. A is for the asymmetric lesion, B is for border irregularity, C is for color differences, in other words, different colors within the lesion itself, and then D stands for diameter, and we're specifically thinking of a diameter or size greater than 6 millimeters. And E represents evolution, so evolution of the lesion in its shape and its size. Now, an ugly duckling sign describes a mole in an individual that differs from all the remaining moles of the body. It's just the one that doesn't fit. And the presence of this sign should also raise the suspicion of melanoma. Here's a picture of a melanoma. Notice that this lesion is asymmetric with irregular borders, and the colors are uneven throughout it. So it gets an A for asymmetry, a B for irregular borders, and a C for the color variation. So the A, B, and C of the ABCDE criteria are met. Now, the diagnosis of melanoma is made based on history, clinical exam, and biopsy. On dermoscopy, the lesion is evaluated for its symmetry, borders, color, diameter, and any new changes. Now, skin biopsy is diagnostic, and excisional biopsy is the preferred technique. And the lesion is excised along with 1 to 3 millimeters of normal skin margin. And when you look at it with histology, you're going to see these nests of atypical melanocytes. Also, immunohistochemistry, or IHC, will show an S100 protein positive. So, what is S100? Well, this is a tumor marker that is positive in neural crest cell tumors. Now, it's not specific for melanoma, because other tumors like neurofibromas and neural sheath tumors can also be S100 positive, but it is helpful. So just remember S100 protein positive. Now let's talk about the management. Surgical excision is the standard treatment for melanoma. A full thickness surgical excision of the lesion with a narrow margin of 5 millimeters is preferred. Now, this allows the determination of tumor depth or thickness, which is also called the Breslow depth, and that's very informative. It helps you get an idea if there's invasion of the tumor to the lymph nodes and neural and vascular structures. Now, a Breslow depth of 1 millimeter or less requires 1 centimeter of a safe margin to be excised. So 1 millimeter down means you want a 1 centimeter of a margin. And a Breslow depth of more than 1 millimeter requires 2 centimeters in order to have a safe margin at excision. And at that point, again, greater than 1 millimeter, you're going to also get a sentinel lymph node biopsy. Now, in terms of pharmacologic treatment after that, you're thinking immunotherapy, ideally BRAF inhibitors, as well as radiation, both of which are used in the case of metastasis. So either way, you excise it, and then if it's metastasized, give BRAF inhibitors and radiation. Finally, let's move on to Mycosis fungoides. Mycosis fungoides is the most common form of cutaneous CD4 positive T-cell lymphoma. It's a fungus-like growth where there are progressive skin lesions. This refers to skin lesions that are initially scaly patches and slowly progress to plaques and generalized erythroderma, and this condition is more common in men. And mycosis fungoides can progress to Sézary syndrome, which is when malignant lymphocytes also enter the blood. Now, patients present with scaly plaques and patches and can be pruritic, and lesions may mimic psoriasis or dermatitis initially. Therefore, a histopathologic examination is required for correct diagnosis in chronic cases. Now, alopecia and generalized erythroderma are some other important features. Sites commonly involved are the buttocks and trunk region. And systemic spread can occur to lymph nodes, the liver, and the spleen. Here's a picture showing a well-demarcated scaly erythematous lesion over the left leg of this patient. And this is a case of mycosis fungoides. Histopathology is the standard diagnostic method for mycosis fungoides. It shows Potrier microabscesses, which are pathognomonic and is formed by intraepidermal aggregates of atypical mononuclear cells. And these atypical cells are also present in the upper dermis of the skin. Microscopy shows Sézary cells, which are atypical mononuclear cells, each having this cerebriform nucleus. Here's a histopathologic slide of a skin biopsy showing nests of lymphocytes in the epidermis. That's referred to as a Potrier microabscess. Finally, let's move on to how you manage it. Topical corticosteroids can be used in the initial stages of the disease, but advanced stage often requires combination therapy. And some important treatment options include total electron skin beam therapy and radiation therapy. A 57-year-old male comes to the physician due to itchy skin lesions. He first noticed these lesions approximately 1 year ago, and they have enlarged since then. Physical exam shows diffuse pruritic plaques, generalized erythema, generalized lymphadenopathy, and hepatosplenomegaly. Complete blood count reveals a leukocyte count of 50,000. What will be found on skin biopsy and blood smear of the samples taken from this patient? So this patient presents with diffuse itchy skin plaques and erythema, lymphadenopathy, and hepatosplenomegaly. And he has leukocytosis with a level of 50,000. Now, all of these findings are consistent with mycosis fungoides, with systemic dissemination, which is also known as Sézary syndrome. And mycosis fungoides is a CD4 positive T-cell malignancy, as we mentioned before, and you're going to see these atypical CD4 positive T-cells aggregating in the epidermis. And that weird name that these aggregations are called are Potrier microabscesses. Now, since this patient also has signs of disseminated disease, like generalized lymphadenopathy, hepatosplenomegaly, and leukocytosis, his blood smear will also show these atypical CD4 positive T cells. And they will have those cerebriform or cloverleaf nuclei. You can call those Sézary cells. And here's a picture of an atypical leukocyte, also known as a Sézary cell. And you can see this on a peripheral blood smear. And notice that this cell has a cerebriform nucleus, and it's actually larger than the surrounding erythrocytes. Okay, now that we've covered the material, let's wrap up with a board-style question. A 62-year-old female comes to the physician due to a skin lesion on her upper lip. She first noticed this lesion approximately 8 months ago, but did not pay attention until it enlarged. She has a past medical history of hypertension. She is a landscape architect. Her vital signs include a temperature of 36.1 degrees Celsius, a blood pressure of 150/95, a heart rate of 85 beats per minute, and a respiratory rate of 16 breaths per minute. The physical exam shows a pearly papule of 5 millimeters on the right upper lip, accompanied by several telangiectasias. Biopsy of the lesion shows intradermal nests of basophilic cells with a palisading pattern. Which of the following is the best next step in the management of this patient? A. Mohs micrographic surgery. B. Full thickness surgical excision with wide margins. C. Imiquimod. Or D. Radiotherapy. Okay, This landscaped architect, with possibly prolonged sun exposure, now presents with a 5 mm pearly papule accompanied by several telangiectasias, and a biopsy of the lesion shows intradermal nests of those basophilic cells with a palisading pattern. So this presentation is most consistent with a basal cell carcinoma. Now, since this patient's basal cell carcinoma is on the face, which is an aesthetically sensitive area, we need to choose a minimally invasive procedure to avoid tissue scarring. And Mohs micrographic surgery is minimally invasive because it sequentially removes very thin layers of skin until there are no malignant cells in the tissue sample underneath the microscope. Therefore, the right answer is option A, Mohs micrographic surgery. And here's the slide that we discussed earlier in this lecture, reminding us of the treatment options for basal cell carcinoma. Now let's discuss why the other options are incorrect. Option B, full thickness surgical excision with wide margins, is incorrect because this patient's basal cell carcinoma is on the face. And like we mentioned before, this is an aesthetically sensitive area. So we're going to go for something like Mohs surgery, which has narrow margins. Now, option C, imiquimod, is incorrect because it is only a second-line therapy for basal cell carcinoma. In other words, you wouldn't go for imiquimod before you go for surgery. You're going to want to surgically remove it. Now, option D, radiotherapy, is incorrect because it's mostly used for unresectable or large tumors. And this patient's tumor is in a surgically accessible area, and it's only 5 mm in diameter. And that concludes our lecture on malignant skin lesions.